Is your healthcare innovative solution getting great initial enrollment, but quickly seeing the retention is very difficult? Patients are dropping off, and that big contract you have is not renewing. Learn why 70% of remote care monitoring systems are failing after enrollment, and the critical component that case management can save in this process so you don't become yet another statistics. Welcome to Provider's Edge, the podcast that helps healthcare entrepreneurs and innovators break down barriers and control their business, life, and future with valuable action steps. With me, your host, Sabrina Runbeck, a recovered clinician and a business deal catalyst. Let's rewrite the rules and create a positive social impact while increasing your profitability. Now, there are so many point solutions coming out of the healthcare system because we understand we have to meet patients where they are. And therefore, the chronic disease monitoring system has been coming out left and right. Some are purely platform-based, some have a wearable attached to them, and some just needed to have the good clinical background with our amazing nurses, caregivers, social workers to come all together to help us from the sick of the sickest to the ones that are actually able. How do we want to ensure we're not just another point value system, but people actually don't adapt? Or they get excited from hearing the new trend in what we can do. But at the end of the day, you don't get the continuous buy-in. And couple weeks, couple months goes by and people stop doing what they're doing. And that could be also mean the scalability is never going to be there. And it's like you're going on the first day. Yay, excitement. But people don't really raise their hand when you ask about the second or third day. So how can we create a relationship with the solution, whether it's tech-enabled or tech-focused? Now we have two amazing people here who are the driver behind our clinicians, nurses, social workers behind the remote monitoring system and how to adapt and create the best solution and not just getting a large funding, but have no way to actually see things moving forward. So I will have Laura and Doug introduce themselves.
Hi, I'm Laura. I've been a nurse for, I really don't want to say how many years, but it's been a really long time. The last 15 years, I've been working with technology companies to develop their apps and their SaaS solutions and also scale different programs for remote patient monitoring using the latest technology. It's amazing. It's a great field. I love it. I am a very strong advocate for it. I would love to see technology used as a standard of care, particularly in chronic conditions. It's so instrumental in helping identify, issues for early intervention, and it truly makes a big difference. So that's a little bit of my soapbox and my background. Doug, I'll let you introduce yourself.
Hi. So I wanted to thank Sabrina for setting this up. So we met years ago on a technology with Clubhouse and other technologies we've kind of kept up with LinkedIn. And we see this network developing in the background with people talking about tech and how there are tech solutions. But like you alluded to, there's very little efforts from the payer side of implementing these programs because let's face it, for them, it might just be another cost. And when business is about reducing cost and increasing profits, even nonprofits have to survive, and they have to increase the sustainability and have the money that's able to keep those things shored up. So I've been a nurse my entire career and been involved with quality management and case management, starting with quality management, transitioning Molina Health Plan into one of the first managed care programs for Medicaid in the state of California, And we did things different back then. We actually had brick and mortar practices with physicians and nurses to see patients before we took on networks. Now we're seeing these networks being taken on with just an insurance card with this virtual network saying they've networked out all these providers. But when it comes to where are they going to go get seen, where are they going to get engaged in their care, there's no place for them. And then many of our hospitals have shut down because of the lucrative contracts that they get stuck into with these shared risk and full risk agreements that were, not really working for that hospital survive. So I've watched this, in my generation, how healthcare has evolved from both ends, from the payer side where I worked for the insurance plans and for the managed service organizations that contracted the insurance plans to the provider networks, to actually working in the hospital as an RN case manager, teaching other RN case managers how to be a case manager and navigate this complex system for the patients, and hoping that those patients will get the good follow-up care post-hospitalization. And we have a long ways to go, Sabrina. We have the technology, but we, like you were saying, they go through that honeymoon or that first date phase, and then they try to implement these programs, but then there's no follow-up with people that have lived and done these programs and understand what to do to sustain these programs. And we're hoping to work with you and other companies to change that with the network of nurses. We call it Nurses to Tech, that are training and taking our CEU courses through our website and getting introduced to the technology companies that really need experienced nurses in case management.
Right. And that's the critical part is we have to have people from all different sides. Most of the time, these companies are scaling and they're very one-dimensional. They are focusing on the solution itself. I'm the best. I'm so unique. Okay. But is there a workflow that's unique enough that you can simply adapt into the people who are carrying out those things, right? And then that need to be a really 3 to 4 dimensional when we're thinking about the mind, body, and soul of the people, the mind, body, and soul of that entire company. And how do you really merge yourself to the harmony, and where people don't feel like, oh, this is another extra step, a burden. I don't see what Doug, you're saying about reimbursement is not that high. I can create a completely separate, maybe surgical tool or a use case that give us a much higher reimbursement. Why are we going for chronic disease, right? What's the outcome? What's the ROI?
Right.
So I feel like we when we're thinking about growth and scale from a solution standpoint, right? These companies who has yet another RPN CCM solution, they have to think about this bigger picture, not just their little cohort environment they're in. And that's why when they start talking to these large health system or physician group, they cannot really truly stand out. I know Laura has a case study we were just talking about right before we hit recording. Can you share with us a little bit of that story again?
The story, what I have seen working with many different practices and many different technology companies, they have great solutions. Unfortunately, it stops at the enrollment process and just the monitoring. And it can't stop there because the patients have to feel like it's important. If they don't feel like it's important enough for a physician to at least look at some of the data and give them guidance, they're disengaged because they don't feel like it's important either. So the most successful programs I have seen have been case management driven, and they look at the whole patient. So this term patient-centric care, it really needs to drive home and be defined. It is patient-centric care. They look at the technology and they use that technology as tangible evidence to make clinical decisions and get the patient involved in those clinical decisions, because you can't argue with your own data. I mean, when you go and you eat that Mars candy bar and your sugar goes up to 200, you're going to know it through the data. And you can look at those triggers, and it's not just glucose management, it's blood pressure management. What triggers your blood pressure? Did you take it? There's so many different medications that patients are on that nobody's really telling them all this stuff and looking at it. So you have to look at the whole big picture. And so case management and technology, when they work together, you have a great marriage. I mean, you truly do. So that's what the direction I would like to see it. You also have to think about this. Chronic disease is the biggest healthcare cost in the U.S. right now. It takes the largest portion of Medicare spending dollars, which is the biggest payer. The baby boomers are moving in. We don't have enough healthcare professionals, to adequately care for them. But technology gives us that opportunity for greater access to care. And it's wonderful when it works in harmony with health and tech. And think about the generation that's coming behind the baby boomers. They've grown up with technology. They've made the wellness industry a billion-dollar industry. They're going to demand this type of care beyond the baby boomers, who really aren't that tech savvy. I mean, I know I'm probably generalizing because there's a lot that are very tech savvy, but a lot of the, your 80-year-olds aren't comfortable. But the next generation behind that, they're going to demand it. And those that aren't in the forefront and can't figure this out with technology and healthcare professionals, they're going to be left behind. And Medicare sees this. I mean, they have approved all these reimbursement codes. Yes, it's not terrific, but it's a start. So let's, see what comes of it. But I'm a very strong advocate of making this work.
What strikes me most about patient management challenges is that we are seeing patients discharged after major surgery like cardiac valve replacements with little to no remote care integration. When I work with over 14 major hospital systems, I witnessed how medical management failed because this leads to readmission. Patients are generally either forgot to take their medication or they have a minor pain or family is worried about their blood pressure, and then there is a late night call. And perhaps if we actually have a monitor at home, they are able to capture those data and we can see as clinicians, then we can correct these errors. Or sometimes people are taking too much medication that they didn't need because their own vitals change once they go home. When we don't have these data points acutely after a major surgery or for any other reason that they have been seen by clinicians for acute care matter, then we do want to have those data points. Otherwise, another appointment is probably not for another few weeks or few months, depending on what the case is. Then the damages are already done. When they come back to the hospital being admitted, it's extra time that they have to spend, and perhaps it is nothing at all. They just felt a little bit weak. That means they actually should have better nutrition and it's not a medical issue, versus that they were having more shortness of breath. They should have taken their water pill and be okay with it. So there's a lot of trouble on both sides of the healthcare system, and therefore founders have to recognize how their solution is playing into a critical gap and making sure to build those solutions and bridge the clinical experience with the technology, and not just isolating saying, well, our solution can be applied in many different cases. When patient is not in the state of mind to understand how to use them, and clinicians has been super busy, then they're not going to adapt any of the solutions, and it just be either a check box they have to take off and not really putting in the effort to see what truly will work in the real life case, or they don't even bother with it, whether it is causing them more issue or perhaps the admin side seeing the reimbursement is not there, they will spend more effort in some other program. Then these remote systems are being dismissed. Yeah, it definitely is. We can see as clinicians, right? Like when I have to make a judgment on tweaking small things, or even from my practice in cardiothoracic surgery, after patient got discharged, most time they got readmitted to the hospital is they took too much of their blood pressure medication. They're hypotensive, or they got pleural effusion again. Maybe they didn't have enough of their water pills, whatever that means. But if there's no monitoring, then the physicians, primary care subspecialty are seeing them week 1, week 2, week 3, whatever that cadence is, but there's still many days of gap of care. So then when we're thinking about the sick of the sickest, we definitely have to monitor them. But at the same time, when I used to do some of internal medicine work where I call the patient about these remote monitoring system, they're like, well, Sabrina, I'm not that sick. I'm only taking this one medication. Oh, my cholesterol is a little high, but I know what to eat. So then it's the false belief of we just know everything. We don't feel bad. Why would we do something extra? Right. And that also is a difficulty for these companies too. And from a hospital sense, okay, if they're not using it, you cannot build it. So what is the actual benefit of having these programs, right? From a structure, workflow, if we pay people to do all these initiatives, but patients are still not engaging in that, then what's the ROI? At the same time, the company have to think about what make your program truly stand out, not just the solution, not just what you're actually monitoring, but how do you get people to change their behavior and make it more interesting, make for them to self-motivated to do.
I am so glad that you brought that up about the blood pressure medicine. That is more common than you think. And unfortunately, they don't see their, cardiologist or their primary until, 4 or 6 weeks out. And they've already stopped taking the medication, or they've taken too much. It's made them feel really horrible. And those are issues. And so that's where the nurse can go in, because it's within our scope of practice to educate that patient, to really look at the trend of that data and not just send them a reminder or an alert saying, hey, your blood pressure is, out of range, which MA can't do that. And so our program is very different because we use nurses, dietitians to work within our scope of practice. And it makes a big difference because we can more than coach those patients. We can educate those patients and we can look at the trend. And so when you have those, nurses working within their scope, we can make a difference, and we can call those physicians and make the early interventions so they don't stop taking their blood pressure medicines, or they take it appropriately, or they get prescribed an appropriate dose. And that is the largest reason for readmissions and is medication.
Exactly. I think the difficult thing is that engagement side, right? And that's why for us, every year we do a big initiative with celebrating the solutions that are actually able to put themselves out there and be rewarded, have the good solutions with the clinical backend. So that's our impact award. Now, that one is where we know people need to have the visibility. So other people who know about them, who perhaps are lurkers, just observing, can actually build enough trust to turn things around. Versus there's a lot of people just don't know, right? Then we can say, hey, you have a pulmonary specialist, remote monitoring. You have diabetes, but there's even the type 1 diabetes continuous monitoring system. There's so many of them, right? What are these solutions out there that actually can collaborate and bring things together that make the most sense? And at the end of the day, who are you actually having in conversation with? And that's the reason we do our annual impact award. At the same time, we also know some people need to talk to people like Laura, like myself, like many experts in the field, or directly with investors on what's that business strategy. And even me and Laura, the whole entire conversation is about the strategic side, that are not just talked about, not just thought about, not using the old school thinking in the current industry, how do you get your market expansion? How do you actually convert, right? Close the deal and not having endless conversation that leads nowhere. And then how do you actually have people that are in your company who are self-motivated, who want to stay and not just like, this is interesting. Let me work on a couple months, but I don't see you moving. I'm leaving. Right. And that's actually very detrimental. When investors coming in for anything, they care about the people as much as the solution behind what they're delivering. Because we all know we can strategize, we can plan all day long. When you don't have the people to do the right thing, or the wrong people are trying to do the right thing, nothing got moved. Right. I know Laura, share a little bit about that side of when you're seeing those poor dynamic in the human design.
What we've done is we've worked with nursing schools and medical assistant schools. So when they're getting towards the end of their program and they have their externships, we are offering externships. There's small numbers right now. And that gives us the opportunity to hire the right person. Because, you can fake an interview and you hire their evil twin and they show up to work and you're like, oh no, what did I do? But we're able through that externship to evaluate critical thinking skills, to evaluate just basically work ethic, and someone that's, optimistic, that's self-driven. That's what we're looking for. We're looking for innovators. We're looking for people with a background. And then you sprinkle in the people that have the experience, because you can't have a whole staff of new grads. So you have those experienced people, but you want those experienced people that mentor and not just dictate. So it's a whole building of a team that meshes and works. But at the end of the day, it's about patient engagement. So you need those people that have the dynamic personalities and the critical thinking skills that can keep those patients engaged, and also have relationships with the physician and the nurses of the clinics that they work for. That's critical too. Doug, what about some of the companies that we've worked with that you've seen that have been successful?
Well, a lot of the companies that reach out to us, they have the RPM. They've scaled that. They know how to deploy the devices, get people to use the app, pair the devices or their cellular devices, and so on and so forth. They can capture the 16 days of monitoring, and they could even have a medical assistant respond to out-of-range readings within 24 hours. But they're missing the component with the CCM. The CCM requires a 24/7 RN that is understanding of that patient's care needs and is already engaged them and put them into a care plan. And isn't that what's missing right now, Sabrina? You mentioned I know your background. I've known you for a while, but I mean, you dealt with the most serious surgeries. You dealt with a person getting a CABG or a valve replacement or something like that. And how many of those surgeries do you feel got entered into a chronic disease management program or even to a transitional care program after that multi-$100,000 surgery? A very small percentage. And we're seeing that. We're seeing that all the time. And so the approach of just scaling up a practice and capturing anybody that has a hypertension diagnosis or a diabetes diagnosis, and they just, cannonballing them with trying to market them into your RPM program, we don't feel that's the right approach. The approach is understanding what the care needs and treating that person as a whole person and talking to them about all the nuances that they should think about their new baseline for their lifestyle now that they have this chronic disease or had that major surgery. And that is led by a nurse that has experience with that. Laura's an experienced dialysis nurse, has been doing that business for a long time. I'm an experienced case manager that has been doing several things from the hospital standpoint to the provider and to the health plan standpoint. And we teach and train nurses that want to get into this career field because it's a specialty. Just like you went into the specialty field of learning how to be a cardiothoracic surgeon, physician assistant. This is a very highly dedicated specialty where you're talking to patients and wanting to get those patients motivated to take control of their care so they can remain healthy at home. Nobody wants to be in a nursing home. Nobody wants to be being dependent on somebody for their ADLs. So as long as we can keep them sustained by managing these simple things as taking those blood pressure medications or those different medications, keep them from getting CHF again and getting exacerbated and, having a pulmonary embolism and things like that. That could be managed by a clinician that knows the signs and symptoms. And nurses, you know what? Nurses can do telehealth. Nurses can call patients and talk to patients. Nurses can direct a patient to an urgent care, talk to that urgent care physician or PA that's working there and let them and send them all of the data that we have on them. So they're prepped when that patient gets there and avoid a hospital admission. And we have programs. There's caregivers, there's home health agencies. Home health does not have to follow a hospitalization. Home health could be assigned from a primary care doctor. It could be assigned from a specialty doctor that sees that need. And so we're trying to connect all those dots. And we have nurses and that we train in this system that is full of nuances. And a bedside nurse just doesn't learn that from their didactic training. Even a physician doesn't learn that. But we feel we need to round that up because we've been living that here in America. And we understand how the American healthcare system works.
Exactly. It's about when we are just talking about academic training, doesn't matter if it's clinical decision or business side of what medicine really means, it's still a concept. That concept has been built years and years ago, and we're repeating the basic foundation of the concept. But practicality is the hands-on part, is how are we engaging with people right now? What are the systems looking at right now? And I work across 14 different major hospital systems across the country. And you're correct. Most of them do not have a remote monitoring system set up. There's only one large system that I have worked with in Missouri that on discharge that I can click on that as an option. Otherwise, I have even personally been in conversation with hospital to see what it could be as a practical engagement. And there are for sure, as clinicians, physicians, and PAs ourselves, having that push, but getting to reverse the top decisions to make the proposal, that takes the extra skill set. And sometimes clinicians, even though we can ask for what we want, but there's no value-based proposition, then you become, oh, you guys always ask for things, right? Which one do we go after first?
Right.
So that's the challenge. And that which means people who are business, right? The tech enable or these CRM, RPM, CCM companies need to be thinking ahead, having those proposals ready. So then when you have a champion in your corner who can make those introduction, it will be much easier way. And most time people don't have that built out. And that's why another reason they're not able to close the gap quicker to get to that conversion and implementation, or at least have some kind of small trial with a small cohort to run with.
You said that hospital, Missouri, the show me state, okay? And I think that's where we're at right now. And we need to show people that this could be done properly and done from a patient-centric standpoint where the patient could ask, hey, I would just like to have a nurse to call and check on me. Because some of my most difficult discharges that I've been able to get out of the hospital that need case management, I've offered tuck-in service. And so I'm saying I will have a caregiver go home with you and your family member and be checking in. She'll be calling back and talking to one of my nurses. And so we've thought of out of the box solutions, but we can't scale in tuck-in service. It costs a lot of money for staffing and for people to be there in person, but we can do a lot with technology to fill that void. And people are, I guess, fear-mongered about AI, but the information that you gather and you feed through your AI is actually going to improve and help us even more when it gets us to highlight the things we need to react to in a faster format when it gets captured by AI. And I think we shouldn't discredit the benefits of AI when it comes to that.
Correct. Because AI is about, if we're feeding the good information, means individual patient's database or the whole cohort of this practice, then it will generate the right information back. It's when we are not contribute to the database that they have right now, then it's sourcing everywhere else that's existing. So if you're not controlling the data, of course, you're not getting the good feedback. When we are active contributors, we're actually improving the quality of what it is. And then that's why the fear of AI, I think people are fearing the different things. That's not the true reality. They simply just needed to be educated properly. And then at the same time, right, there are people using AI the wrong way, but it doesn't mean everybody is tethered or doing the wrong thing. No one on purpose is doing that, right? We can have the fear of that. But I think a majority of why people got into healthcare wellness in general is about positive movements towards something of a common good.
Yeah. And let's face the facts. Right now we have millions of people that are on managed care, millions of people that have Medicare unassigned, and we're very marginal with the amount of people that are being managed properly. It's very marginal. And they're being offered right now. It's open enrollment. I think it's just closed.
I think it's
yeah,
closed.
And they're being offered, little credit cards or gift cards to go to the drugstore. They're being offered all these different services. But when it comes down to after they've captured their membership, are they really being engaged? And I've tried to scale large HEDIS programs and make sure everybody get their annual wellness visits, make sure they're getting the HbA1c double checked and all these other things. And you could scale that by doing some informatics and running your population and see who needs this. But I don't think you can really, they're trying to use that approach with RPM programs. I don't think that might give you a inventory of people that you should reach out to, but really the engagement needs to be more intense and needs to be more intimate with that person that is speaking to the doctor, having that treatment plan by the physician or the provider, and then somebody following up with that treatment plan and letting them know. Even to date, if you ask all the people that are on RPM programs, one of the most hindering factors is they don't even want to pay the copay. So this person doesn't even see the value of making a $20 copay for an RPM program. And a lot of people drop off now, why is that? They would spend $20 on Starbucks, yet they won't spend $20 on a copay for an RPM program. To me, you've approached the wrong person with this, and you haven't made a sense of urgency of why they're going to do this and why this will keep them healthy at home, as opposed to having an exacerbated condition and going from that maybe needing a cardiothoracic surgeon to somebody that could be medically managed with medications. And it really comes down to that. You know how intense a surgery is, and people need to realize that they could be managed to prevent these. And Laura saw people that could be managed to prevent having renal failure and end up on dialysis the rest of their life. This is what people need, because those are last-ditch efforts that our medical system employs, but it's not something we should want to be doing with the large amount of our population as these baby boomers hit, because we will just go bankrupt. We will have more and more hospitals will close down because they're getting low reimbursement. More and more clinics will be closed down because there's just burnout and there's nobody wanting to work in these clinics. And that's really what's happened in the last few years. We've seen a lot of hospitals and clinics close down out of failing programs. And we need to turn this around.
Yes.
The care plan approach completely transforms how we think about health tech implementation. We see firsthand how treating care plan as living documents, not just data collection tools, makes all the difference in patient engagement. The most successful healthcare technology solution understand that their technology must fit into a comprehensive framework that addresses the whole patient journey, not just isolated data points. When we align clinical workflow with technology and ensure nurses can work within their scope of practice to educate patients and provide timely interventions, we create a system where technology enhance rather than complicate care. So my question for you is, are your healthcare solution built around comprehensive care plan that clinicians will actually use? And how do you make sure of that? Now, if you are a founder, a healthcare leader that has amazing solution that deserve to be spotlighted, then we would love to feature you, whether it's on our podcast or our game show. Contact us at SabrinaRunbeck.com or directly apply at theprovidersedge.com. And we would love to see you.
It's the rural hospitals. I mean, they've all closed down, and that's limited access to care for a large population and that lives an hour away, from a physician. That's a problem. I mean, it truly is. So you need to have somebody monitoring them and looking at them and calling them and saying, hey, how are you doing? Find out what their priorities are. We have one of our courses that focuses on care plans. And I have to admit, when I was in nursing school years ago, I thought they were the most time-consuming, irrelevant things in the world. Now, I'm a very strong proponent of them because that care plan needs to be a living document. It needs to tell you where the patient is, what their desires or outcomes are, how you're going to get there, and how you're going to measure it. And we've worked with so many technology companies that don't get that. Their care plans are just gathering data, but what are they doing with the data? Nothing.
Right. So that's the key component of business need to run like a care plan. You need to know where your who's your end user is, your B2B, B2C, what's their end goal, what's their challenges, and then how are you taking them there? That need to be very specific. And then who's keep track of quality control, helping people move forward in the next step. So they need to think about a same system that's simply duplicated in different arena instead of seeing things separately, right? Laura, like you're saying, most people are thinking it's just like data collection. Well, even it's a data collection as the goal, what are you going to use the data for? How are you going to improve the patient or your organization that you're connected with, or even yourself to say, we're able to help so many people in this stage of health to go to the ABCD level of health, where there's a cost reduction, there's a last visit, there's a blah, 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 right? So I think when people are building these programs, they need to use the same applicable framework. That's the things that caught them up is they lose framework. And then that's why we even run our own game show, right? Every month we gather experts on the panel from investors for business strategists, operational efficiency, experts to say, hey, we want these founders, tech-enabled or tech companies to come together to do a competition. You need to be able to pitch us within 2 minutes. Not so much about funding, but the same storytelling way, outcome-driven way need to be communicated with all key players. Otherwise, how will we know if this is something that we even understand or care for to even support you, right? And then is you have to tell us the solution of how you're going to implement a program or business expansion or even convert the sale, right? If we can hear you talking about a solution that people will never buy in, then no matter what, you can say, oh, I just need to do more work. Okay, go talk to 100 people. If all 100 people, you only have 5% conversion, guess what? It's messaging. It's your approach. Perhaps you actually don't know what people want. Just because you do more things, it doesn't mean you'll get anywhere, right? So that's when people can actually have the hands-on experience with us to really quickly accelerate what they can do to engage better with the patients, better with themselves, and not spinning the wheels all the time. I think too often people talk about the problems, but never get down to the ground root to say, what do I have to do now? Let me get the right people to share and break things down for me. And now I can have a really tangible way, just go for it and not keep going after superficial solutions.
Let me circle back, Sabrina, because I think you brought up a point, and as we as nurses and providers, we talk a lot about reconciling medications, but what if but we kind of work in silos, and that's part of the reason we have to reconcile medications, because the cardiologist prescribes one thing, but then that what they prescribe would be ruinous for what the ophthalmologist prescribed for their glaucoma or something like that. And and we have to reconcile that. And sometimes we can catch that with pharmacy alerts and things like that. But what about the other part of things where we fragmented our healthcare system? And that's with the treatment plans. And it has to start with that treatment plan and that engagement. And so the hospitalist is going to write a discharge summary and a treatment plan, but that hospitalist is siloed out from that primary care doctor that does not go to the hospital, doesn't even have privileges there. And then we're trying to get them back into that network. The cardiologist in the hospital is most likely not the same cardiologist that's going to see them as an outpatient, unless they're lucky that they live in an area where they've kind of built up a great professional network around that hospital. But in reality, where I live in Los Angeles, it's very fragmented. It's very convoluted. And if we could circle back and think about who's going to reconcile those treatment plans and to put into the whole person care plan, that's going to be a nurse that understands that bigger picture, that could look at the diagnostics, could look at the imaging, could look at the labs, and look at all those treatment plans and medications and see that the reconciliation was done, and have those conversations with the patient, but not just with the patient, but with the care team that they need to navigate this system through. Healthcare is complicated, and I spoke earlier about AI can help us out, but at the end of the day, it needs a human thinking through this stuff and working with the nuances that family member is telling you that, well, my mom's kind of isolated. We're all working and she's not able to take care of herself when she's home alone and things like that. We have to bring in all those nuances, because if they can't even get transportation to go to their physical therapy and you're trying to recover from that, give them, rebuild their strength training that they lost and whatever they're trying to do, that's a huge hindrance. And we can keep throwing these phone numbers and 24-hour numbers and services that we say that we're offering with Medicare Part C. But unless you have somebody granularly instrumenting those things, they're not getting done. They are not getting done. And that's why we have large health plans with millions of members, yet only thousands of patients in chronic disease management programs. It should be hundreds of thousands, and if not millions, with bigger plans.
Right. Yeah. These type of conversation can go endless, right? Because we can say who is the bridge, right? We identify the nurses, the social workers, our case management are the bridge to can synthesize the information, delivery, connect, and figure out the gaps, quality control. And then we also know solutions come from the individual tech companies that has able to build a platform, a device, a ways that we can get in touch with these patients and help us perhaps onboard and then keep going with adapting the workflow. Then we also needed to have the authority body, right? The people at the end of the day, the clinicians, as the physicians, the PAs, the NPs, the people who are actually doing the decision making behind all the data.
Be able to click that button as you put it, and then say, and talking to that patient, a nurse is going to be calling you and making your care plan. And that's a critical component of your follow-up for this care plan that I just gave you.
Correct. So we needed to have buy-in from all different perspectives, as well as having the workflow that are able to customize into each system, each practice. And that is what takes time. However, if you can build it right, that's what scalability comes in. And that also means you cannot have one plan or one business model that you think you can push to everybody. You need to have the experts from these domains to come together. Well, we appreciate all the amazing things that input you guys have put in for us, and definitely more people from both the hospital admin side, the case manager side, as well as our technology innovator side need to be able to watch this episode to think about how they are implementing and having the right conversation to make sure these workflows are built out properly. So we can't wait for more things that coming out of the pipeline for our chronic disease patients to be able to leverage and have a better solution as we move forward in 2025. Until next time.
It's going to be a great year.
The first day phenomenon in healthcare technology is real. 70% of remote monitoring systems fail after enrollment because they focus solely on the technology itself while neglecting the human element of care. Throughout our eye-opening conversation with our two case management experts, we discovered why healthcare technology founders generally who has had paid users on their platform, yet still struggling with patient engagement beyond the initial implementation. Most technology companies excel at enrollment and data collection, but fail at maintaining patient engagement because they don't integrate care management into their solution. And even they have initial great relationship with the clinics and hospital system, when they don't know how to create additional benefit or be able to also create revenue for those hospital for saving aspects, at the end of the day, they might be focusing their energy on something that has a bigger impact on their system or their patient load. Now, case managers and nurses can serve as a vital bridge between technology and patient outcome. They can transform raw data into meaningful interactions that patient actually care. Medication management failures are the leading cause of hospital readmission, with most patients not seeing specialists until 4 to 6 weeks after discharge, or even on routine visits 4 to 6 months in between visits. Therefore, it's an extensive amount of time that errors might occur when we have no idea what's happening with these patients. Successful health tech solutions treat care plan as living document, not just data collection tools, and measuring outcome that matters to patient is the key. The integration of clinical workflow with technology creates solutions clinicians actually want to use, rather than adding them as administrative burdens. Remote monitoring doesn't work without clinical expertise. When patients feel their data isn't important enough for clinical review and then disengage, or they feel like they are quote-unquote healthy and they don't need to be monitored, that means they are not seeing the value of why these systems do exist. Even as AI advances, the human element remains essential. Technology should enhance, not replace, the vital roles clinicians play in patient care. We've seen it firsthand across multiple hospitals. Technology do exist, and technology really trying to push into the door. But without proper clinical integration that's not already built into the existing technology these clinicians and hospitals use, then it's making it more work than integrated into something that's already very easy. And patients also can lose interest, and therefore this technology fail to scale. Now my question to you is your health tech solution truly built around comprehensive care plans that clinicians will champion? Or are you still trapped in the first day phase of your users? Thank you for tuning in to Provider's Edge podcast. We hope you enjoy our latest episode and found the insights and tips helpful. We'd love to hear your feedback on the show and learn what topics you'd like us to cover in the future. So please take a moment to leave us a review on your favorite podcast platform and let us know what you think. Your feedback is essential to help us improve the show and provide you with the content you need to take your healthcare business to the next level. Thank you for your support, and we look forward to hearing from you soon.